as I mentioned, right, the talk here is about myositis mimics. So we'll go over some cases. If there's time, there's something interesting about myocyte signaling, which I find fascinating and a change in the field, hence the title Muscle Talk. So a little joke, hard to see people laughing on Twitter and Zoom here. But anyways, I think muscle is beautiful. And I put a slide here of one of the cases that we'll talk about. And these come from experience over time during fellowship and myself when I'm seeing these patients, but really just beautiful cases in muscle pathology that we'll talk about. So I have some titles for the cases here, and just to reemphasize that we often learn things during our clinical training and work independently that we didn't learn in medical school. The field's constantly changing, and I think that's what's beautiful about it. Right, it requires continuing education, it requires discovery and discussion with your colleagues. There's always something new to be learned from patients and from our mentors, from our colleagues, from our students. So the first point, as I was saying, that not everything inflammatory is polymyositis, and even that polymyositis bucket is becoming smaller and smaller, which I'll highlight some cases here. But just as a point of reference, polymyositis was the bucket term for inflammatory myopathies over 100 years ago. And then that split to dermatomyositis and polymyositis, which then later split to include IBM, necrotizing myopathy, antisynthetase syndrome, and that polymyositis bucket is becoming smaller and smaller. We know that dermatomyositis, several different antibodies that are associated with it, and that itself is becoming broken down into several other disease states. So inflammation on the biopsy doesn't just mean that it's myositis. There's several different kinds of diseases that can look that way on muscle pathology. So it's important to keep in mind that that's just, even though it's tissue and that's a gold standard kind of test, it's just one piece of the data. Ultimately, it's the patient in front of you and the data that they present to you. So let's talk about a case here. I titled it Hickham's Dictum or Occam's Razor. That picture there gives the answer to the case. It's not this patient in particular, but it's a reference to what the case is about. So this is a 73-year-old gentleman with a history of CLL, IgM polyclonal paraproteinemia, pulmonary sarcoid, and he comes in with leg weakness. So just generally, you can already tell that this is a prolonged course, right? So when I speak with students and residents and myself, when I approach cases, I'm trying to understand what the time course is, where's the localization, and what's the progression been like. I think that gives you enough information to go about the rest of your H&P. So try and keep that in mind as we talk about these patients. So back in 2009, this patient had CLL and was being treated. No muscle symptoms at that time, no fatigue. And then later that year, he was working as a surgeon, but noticed that perhaps he was getting a little bit weaker, particularly with skiing. And then that weakness and fatigue continued to progress quite slowly. And in the mid-2010s, his fatigue was more pronounced. He had mood swings. There were some episodes of confusion, perhaps related to calcium-related issues. And then in 2018 and 19, that's when his weakness really began to come to true form. He had difficulty walking. He had trouble climbing upstairs. He had trouble standing from a seated position. And that's when treatment was started. That's when we got involved. Just some points here to point out for his history. One, I think that late 2009, that skiing form, we push and pull on people's muscles. All right, that's a little bit rudimentary. Right. And I think the clinical picture, patients can often tell you that they have symptoms and signs before you can feel them or see them. So I think that's important to keep in mind. Perhaps there's grip strength weakness at that time. In the age of telemedicine, one of the tests that I use, and even just when they're in the office, is to ask them, can they stand from a seated position without using their arms? Can they climb upstairs? Those to me suggest proximal leg weakness if it's not possible. And then continuing on, there's no neuromuscular disease here in the family, no bad habits, and the medications he's on are listed there. There's no statin listed. And I mentioned that because statins are associated with necrotizing myopathy, a different presentation, but something to keep in mind. His exam I list here, so quite detailed, but we'll go through it, right? Because it's important to help localize what bucket are you going to put this patient in? Is it inflammatory? Is it infectious? Is it malignancy? Is it degenerative? right? That intuition comes from your history and physical. So mental status, cranial nerves, sensory exam were all normal, as was his cerebellar testing. Motor exam we'll go over momentarily. That's where the money is for his weakness, right, and the symptoms that he's having. His reflexes, he had drop reflexes in the ankles. Otherwise, it seemed to be relatively symmetric and okay. Babinski was negative. It wasn't present. He had a slow gait. He was able to stand on his toes and heels. You see that he has quite pronounced proximal weakness, no hand weakness that we detected on exam. And then there appeared to be a potential foot drop on the right side. His labs I list for you. His CK was normal, as was his aldolase. His ESR was a bit elevated, likely related to the paraproteinemia. VEGF looking for POEMs, that was negative. And then several endocrine myopathy labs, so vitamin D, PTH, calcium, normal. Interestingly, peripheral blood flow cytometry showed an unusual finding, T-cell large granular lymphocytes. Again, that's a clue to the answer here. And he had his known CLL. SPEP showed a polyclonal hypergammaglobulinemia. You worry about amyloid in some of these patients. They can have proximal weakness as well, but they typically have multi-system involvement, right? You'd expect that their kidney function is decreasing. They may have a neuropathy as well. Their cardiac system can be involved. And then FDG PET showed uptake in all proximal muscles of all limbs. Another important point there that we'll go over in a moment. EMG showed a myopathy, which we suspected from history to begin with. So to talk about him as a full picture, right? If you were to describe him, I want you to take a second and make a one-liner for this gentleman. And I can go back here. And what I would say again is you want to know what the context is for his symptoms, right? So that's part of that one line there. Where's the disease? So where are you localizing to? What's the progression? And what's the chronicity? And so what I would say is that this is a 73-year-old gentleman with a history of pulmonary sarcoid. He's got CLL, he's got a paraproteinemia, who has this chronic, slowly progressive, right? It's not relapsing, remitting, and it's just, there's no flares that we've noted. Chronically, slowly progressive muscle weakness. So I think it's a myopathy. That's your hypothesis that then you prove with your testing. And so my exam, yes, it shows a proximal pattern of weakness. And my EMG also confirms that this looks like a myopathy. Don't let the CK deter you. It's important for you to know what the labs mean and what they don't mean. What are the pitfalls of the labs? So don't be deterred by normal lab values or abnormal lab values if your history and physical point you in the right direction. All right, so let's talk about this gentleman's context, right? What are the underlying conditions and how might that play a role in his presentation? Well, we know CLL is associated with autoimmunity. You get various cytopenias. You can see that T-cell large granular lymphocytopenias, TLGL, and inclusion body myositis, a particular form of myopathy, which is thought to be degenerative as well as autoimmune. The verdict's out. We can't treat it. It doesn't respond to immunosuppression. It shows up with a higher predisposition in CLL versus the general population. So that's one association, perhaps suggesting why this patient looks this way. On biopsy, whenever you take a look at these patients with inclusion body myositis, you do see these B-cell infiltrates with this TLGL as well as CLL. So different forms of inflammatory cells that you can see. And then on the bottom, the endomesial inflammation with rim vacuoles, that's a suggestion that inclusion body myositis is there. So with TLGL, what we see here is that when you have it, and these patients have inclusion body myositis, it correlates with the aggressiveness of the disorder. So the greater the expansion of TLGL, the greater the aggressiveness of inclusion body myositis. So these patients weaken faster and faster if there's greater TLGL expansion versus if they don't have it. And we don't see it in the healthy population. So again, some slides on muscle pathology to show that we do see these T-cell infiltrates within inclusion body myositis, and they invade the muscle fibers. That's the bottom slide there. Again, another association that's important to keep in mind as we examine our patients. Something important I think that we should all be working on, something that I always work on, is what to throw in and what to throw out, right? I think when you tell your patient, hey, you have a neuropathy, they Google neuropathy. But what I tell my trainees is you should be able to Google better than your patients, right? You need to know what's important. You need to know what the localization is so that you can search. So if you search for myopathy and TLGL, you'll find inclusion body myositis. Other considerations here, right? So we know that he has pulmonary sarcoid, and we saw uptake of PET tracer in his muscles. So there's an active process happening, but what is it? So with granulomatous myopathies, right, granulomas that you see in sarcoid, when you see granulomas on biopsy, it doesn't automatically mean sarcoid. You can see it in inclusion body myositis as well as these rare causes, such as like ulcerative colitis, myasthenia. You may see that as well. The typical presentation for these patients is that they have distal weakness greater than proximal weakness, and they may have dysphagia as well. It's milder compared to sarcoid when you just have granulomatous changes on muscle biopsy that's not otherwise specified. And CK is relatively normal to mild elevations. So that's one entity to think about as well for the diagnosis. Another entity to think about is sarcoid myopathy, right? So if we were to unify this diagnosis, we would say, well, one path, he has pulmonary sarcoid, he's weak. Is it sarcoid myopathy? Another path could be, well, he has pulmonary sarcoid, perhaps it's isolated, but he has CLL and TLGL. Is this going down inclusion body myositis? With sarcoid myopathy, you get three different kinds of myopathies. You can get this chronic form, a very slowly progressive. CK is normal to mild. It relates to muscle necrosis. So if something's going slowly, you would expect, yes, that the CK wouldn't be so high. You have a nodular form. So these patients have nodules that you can feel on their muscles or see on imaging. They typically aren't weak, and CK is typically normal. And then the acute form, which presents more nefariously, where they get this flare, CK is quite elevated. And then there's overlap with polymyositis, dermatomyositis, inclusion body myositis. When it overlaps with so many things, I think all that means is we don't know what we're doing. So you need to think very carefully about what the clinical phenotype is. The reason is because we're immunosuppressing these patients to treat them. IBM doesn't respond. Sarcoid should, dermato should, poly should. And in the age of COVID, we don't want to immunosuppress people unnecessarily and put them at higher risk. So we do see with sarcoid myopathy that not all of these patients respond. So this was the patient's biopsy, and right in the middle of the screen, you can see that granuloma. And so yes, we see a granulomatous myopathy here. Is it sarcoid? Is it isolated? Is it inclusion body myositis? So another important lesson from this case is to look at your own data. So I'll point you towards the FDG PET of the patient. It was read as uptake in the proximal muscles of all limbs. But in fact, you see that the rectus femoris bilaterally was not included, right? It wasn't lighting up the way the rest of the quadriceps muscles were. That's specific and quite unique to inclusion body myositis. So the MRI example below shows what we normally see, where you don't see hyperintensities in the rectus femoris. So that's a point towards inclusion body myositis. This patient's biopsy had a granuloma, so it could go either way, but P62 staining on the bottom right was positive. So again, a specific finding for inclusion body myositis. Other things to support IBM, the NT5C1A antibody was positive, which is sensitive and specific, but we have to keep in mind it overlaps with Sjogren's, sometimes scleroderma, lupus. There's overlap that it's not a guarantee, but again, it's the clinical picture. TLGL was expanded, FDG PET, I just showed that, and then the P62. So if we were to diagnose this patient, decide what to treat him as, well, the lab, the FDG PET, and the biopsy suggest IBM. And so will this fully progress to the IBM phenotype, which is hand weakness, so finger flexion, which is unique, and quadriceps weakness, so they can't extend their knee. Most myositis has proximal weakness, so you ask them to raise their arm up and they have difficulty. Their shoulder girdle is weak and they can't stand from a chair because their hips are weak. So it has a very unique phenotype, and we know it doesn't respond to treatment. IBMs have granuloma, so perhaps there's overlapping biopsy features here that we're just recognizing, and these cases are rare, so we're not quite sure. Sarcoid and IBM share an HLA haplotype, and it's related to IL-1 elevation. So perhaps there's this underlying genetic underpinning where they show up together. And lastly, IBM features, so finger flexion weakness, rim vacuoles, the antibody. If you find those in sarcoid, that tells you that there's likely to be a poor progression. It's kind of a circular argument, but that makes sense because it may be more IBM contribution versus sarcoid. We put this patient on steroids and he got, quote, 50% better, but not a full response. And so in a case like this, the way we concluded is that there's likely a contribution from this granulomatous myopathy, possibly sarcoid, but there's also evidence that there's IBM in this patient. So we wouldn't expect a full response. Again, important so that you don't escalate therapy, trying to get back full strength. So that's case number one. The learning points from there, again, that inclusion body myositis, right? We have finger flexor weakness, proximal leg weakness, which is different from the other myositis subtypes, and that there's overlap with sarcoid myopathy. The next case here, again, a peripheral smear here that gives you the answer, not from this patient, but related to the case. Here's a 70-year-old man with diabetes. He has a neurogenic bladder and he has difficulty standing from a chair. Again, think about that progression, where's the localization and what's been the course. So you can already tell that this has been a chronic course here, given the number of years. He had difficulty standing from a low chair and his CK was elevated. That's enough to tell you, yes, this looks like a myopathy already. He had a quad biopsy that was normal. Don't let that deter you, but keep that in mind. He was treated with steroids and it seemed to help. Steroids were stopped and his symptoms came back. He had another biopsy. It suggested inflammatory myopathy. Steroids were restarted. It didn't help. His weakness slowly progressed over the next 10 years and he needed a walker. Again, tried all sorts of immunosuppressants, didn't help. He had EMGs, MRIs that showed polyradiculopathies. He had a laminectomy. And you'll notice as our patients age, they have multiple comorbidities. And it can get difficult to say what is contributing to what. Do we put a patient through surgery? Do we increase immunosuppression? That's why it's important to localize the best you can and keep the patient context in mind. His CK was elevated to 2,000 to 5,000. He had another biopsy that suggested inflammatory myopathy. He needed a wheelchair to do longer distances. So again, take a moment and create a one-liner that you can base your foundation off to do that vindicate model, right? To come up with that differential, vascular, inflammatory, neoplastic, right? Go through and say, where do I think this patient's gonna land? His review of systems was negative for any oculobulbar symptoms, no neuromuscular diseases. He's from Trinidad, no bad habits, no statin. Again, that's the necrotizing myopathy component. CK is typically higher and they end up with proximal weakness. And those necrotizing myopathies show up more acutely. So they definitely have weakness and it doesn't take several years like this to show up. His exam here, you can tell something's been chronic here because he's had decreased bulk in his arms. He had upgoing toes, and then he had a length-dependent small and large fiber neuropathy. Right, so a few more things happening here than the last case. You can see from the exam, we grade it from 1 through 5. I should explain what that means. 5 is full strength. 4 means that they're able to hold strength as you push against it, but you can knock it down. Then we do pluses and minuses to help us grade that. 3 is anti-gravity only, so they can just hold it up. 2 means without gravity, so it's as if you're doing a biceps curl, but now you make it horizontal. Right? So gravity is not affecting your arm. And 1 is just a twitch. So you can see his hip flexors were 2s. He had some distal hand weakness as well as proximal weakness in the shoulders. CK was elevated, and then an EMG did not suggest a myopathy. So again, take a moment here and take tally of your tests in the clinical picture. CK is elevated, biopsy kept showing myositis. He was treated for myositis, perhaps responded, perhaps didn't respond at some point. What do we do? He had lumbar surgery to help with some of that polyradiculopathy, didn't fix his symptoms, perhaps was not necessary. All right. So I included his biopsy here. We see endomesial infiltrates. And so those are the blue looking cells right there on the bottom left invading the muscle fiber. There's some tissue artifact there, but what you're seeing on the top left is fiber size variation. So these muscles have been affected for quite some time. They look a bit rounded, which may suggest that there could be perhaps a myopathic process on, but not necessarily. And then we have different stains here on the bottom right. You can see rim vacuoles as well as MHC1 upregulation on the top right. So, the way you think about this, the way we go through our differential is to put pieces together, what's relevant and what's not relevant. So on the top on the left there, we have perhaps he has a myelopathy. He's got a neurogenic bladder. Everyone as they get older seems to have bladder issues. Do we throw that out or do we use it? Trust your exam. If you saw an upgoing toe, don't just write it off. It means something. There's an upper motor neuron sign. Myopathy should not cause that. Neither should a peripheral neuropathy, which he had as well. So going through your differential, putting these pieces together in and out, right? Iterate, let it be hypothesis generating to then come to an answer. So polymyositis, right? Is this the answer? He was treated for it. He had an inflammatory biopsy, but he didn't respond to steroids. These patients typically do. He had distal weakness, which is not typical of polymyositis. It's more proximal. And if it's untreated for quite some time, sure, you can get some distal weakness that develops, but it just wasn't feeling that way. That didn't seem to be the case, right? He'd never really responded to steroids. Inclusion body myositis, he had the inflammatory biopsy. The pattern doesn't fully fit. He had the proximal arm weakness. The CK was a bit too high, 2000s to 5000s. Normally you only see it 1 to 10 times elevated. So it can be normal. And typically the upper limit of normal is 200, which is not always the case. Physiologic elevations can be higher, and neurogenic etiologies can also raise CK. So ALS patients can have a CK of 1000. So don't be fooled and don't rely simply on just a number to point you in a direction. But IBM can be normal up to 10 times or so. Diabetes can cause a lot of different issues and can make your exam and a clinical conclusion quite muddied. It can cause a polyneuropathy. You got polyradiculopathies, neurogenic bladder. It shouldn't really cause an upgoing toe. And then myeloneuropathy. In neurology, we love combining different localizations. So is there a myelopathy? That could be separate. Is there a neuropathy? Is there a myeloneuropathy? Well, the Babinski sign was there. Polyneuropathy, neurogenic bladder, all fitting with myeloneuropathy. CK was elevated quite high, a little bit more than what we would like for a neuropathy, a neurogenic cause. So nothing fits perfectly. So perhaps there's multiple things happening. If you add in his geographic origin, that may give you a clue. So I'll stop there for a second and let you think where that clue would lead you to. All right. And that was the diagnosis. So from Trinidad Tobago, HTLV is endemic. We sent this lab and it was positive, which would help explain a lot of these symptoms here. So let me go over how it fits in. All right, so there's Trinidad and Tobago, and you can see that HTLV is in several different areas of the world, Afro-Caribbean, West African region. But you also see that Japan is endemic as well, an association I never had, through all our STEP questions and different test banks. But looking at this case and doing more research on it, it's endemic in Japan as well. It's a retrovirus, 5 to 20 million folks are affected, and there's a higher prevalence in women. The transmission, mother to child, sexual contact, IV drug use, and then HTLV-associated myelopathy occurs more often in the Trinidadian population versus the Japanese. The first paper that talked about it, you can see that upper limb weakness has been reported in the patients that this study pointed out. There's 25 patients, and you see that bladder symptoms are quite common, actually. It's typically this subacute chronic progress, really slow. It takes about 20 years for these patients to end up in a wheelchair. They're spastic. They have a neuropathy, they have low back pain. Who doesn't have lumbar degenerative changes, constipation, bladder issues? And then the CSF right? When you think of myelopathy, it's a clinical diagnosis, right? Your MRI can be normal, your CSF can be normal. You really rely on your exam to localize it and to chase it. Something that you can see in these chronic myelopathies, whether it's HIV or HTLV, is thoracic cord thinning. Radiologists don't always pick up on it, and we have the upper hand because we localized it to a certain area. So if you're concerned about a myelopathy, look at your own images, think of where the lesion should be and what you should be finding. Right? So if you think it's a myelopathy, don't let relatively normal CSF deter you. Don't let normal imaging deter you. Those are your tools to support your hypothesis. If they're negative, don't let that move you to a different differential. Just incorporate it and see how it all comes together. I think from reading about HTLV, it seems like it's another great mimicker like syphilis. It seems to be associated with several different diseases, especially HTLV1, which is what this patient had. And polymyositis is one of those. So inflammatory myopathies, HTLV is associated with it. And one of the case series that talked about this, the original one, went through different biopsies, and they were diagnosed with polymyositis and inclusion body myositis more often. The pathology that I showed you, the endomysial inflammation, right in the middle of the muscle fiber versus the outside of the muscle fiber where dermatomyositis is typically affected. That's called perifascicular. It's more associated with that middle inflammation, so polymyositis and IBM. These patients don't respond to treatment. It just happens to have a similar overlap. You see that CK is elevated in most patients. You find HTLV positive, and then ESR is elevated as well. It's typically not elevated in myositis unless there's lung involvement with antisynthetase syndrome. So again, I think another mimicker here to think about. So not all inflammation is polymyositis. That flower cell, the thing that I pointed out in the beginning, on peripheral smear, you see that sometimes with HTLV. Another punny title here that I thought was quite clever, and it makes me laugh. So hopefully you enjoy it too. B2 or not B2, there's no question here, and that's the answer to the case. I won't go over the nitty gritty of biochemistry. I know that brings horrors to students. It's a very testable area. But this is a case of a 49-year-old woman with leg weakness. So she has a history of seizures and difficulty walking, and she's been having falls. So she initially came in around 2019, and she was admitted for nausea and vomiting. That soon resolved, but a month later, she had difficulty walking with low intensity exercise. She needed a walker, and eventually she had trouble standing from a seated position. Her CK was elevated 800s to 3900s. MRI thighs was negative. That's a test that I found rheumatologists use more than neurologists and neuromuscular doctors, and I think we should use it more. It gives us this larger view, this biopsy basically, of what the muscle is looking like. I would caution you though, I often see it read as there's hyperintensities in the muscle. This is consistent with myositis. And I would point out that it's a picture, right? The clinical correlation is up to you. That radioclinical correlation is what you have to determine. Sure, the differential is myositis, but that's not the only thing. This patient had a myositis panel and antibodies sent, rheumatologic antibodies, those were negative. And then there was concern for functional overlay for this patient. Several different doctors evaluated her and thought there was something not lining up here. She had multiple admissions and then a muscle biopsy that said, well, this looks like mild myositis. She had an EMG that was, quote, consistent with polymyositis and dermatomyositis. And then she was treated for such a diagnosis. Very mild improvement, but nothing significant. Again, to know what your tests mean, an EMG tells you a process, a localization. Is it the nerve? If it's the nerve, is it motor or sensory? If it's the nerve, is it axonal or demyelinating? Is it the neuron, sensory ganglion or motor neuron? Is it a radiculopathy? Is it a neuromuscular junction, pre or postsynaptic? Is it the muscle itself? Right, so this EMG should have said this is an irritative myopathy and stop there. The differential includes myositis, but that doesn't mean it's consistent with myositis. So steroids weren't helping, CK was normal, had a limb girdle, muscular dystrophy panel sent that didn't fit her syndrome, and then we sent off several different diagnostic labs. There's no family history of neuromuscular diseases, no bad habits. I put the husband passed away there because just as a caution that, we sometimes look to prove a functional neurologic diagnosis, and we look for reasons why that would be true. So patient's husband passed away, she was stressed, and perhaps that means that there's still a functional neurologic disorder. I know I've been burned by it, where I think my lesson now is treat it as organic and rule it out, so that in your mind, there's nothing left other than a functional neurologic disorder. I think starting off with that diagnosis can be difficult and tricky. She was on a statin that was stopped, again, speaking to that necrotizing myopathy. And I should add, I keep mentioning the necrotizing myopathy. There's two antibodies, HMGCR, which is associated with statins, and SRP. There's also antibody negative. HMGCR responds quite well to treatment, IVIG, and SRP does not. Some patients respond really well to rituximab. They can be paraneoplastic, so it's worth searching for cancers. This patient here, going back to her, she only had proximal leg weakness. She had difficulty standing, which we knew, so we suspect that there's going to be hip girdle weakness. She had a neuropathy as well, length dependent, and then her biopsy showed several different things. There was some endomysial inflammation, MHC1 upregulation, so a suggestion that there's an inflammatory process, but not unique to it. There's also abnormal lipid droplets. So we should not throw that out because that gives us the clue and the answer. For CK, we noted that was normal to elevated and aldolase was elevated. Aldolase I find useful here because not just this case, but when we think about myositis with that perifascicular involvement, remember the muscle is like this ring here, right? And around the edges, if you're getting perifascicular, sometimes you only see aldolase elevation. So if CK is normal and you check aldolase, which is elevated, and you think it's a dermatomyositis, then it's worth chasing that a bit further. There's her rheumatologic labs. Her myositis antibody panel is negative, and then several other labs. So NT5C1A, we discussed with inclusion body myositis, but the acylcarnitine profile was elevated. We'll talk about that momentarily. And then the EMG I mentioned as well, consistent with polymyositis, which was not the case here. So how do we get to the diagnosis in a patient like this? Well, I think most of our answer typically comes from the history, right? I remember in residency, when you get so busy, you like to do your chart biopsy first, talk to the patient for 2 minutes, do a quick exam, and then you have your answer. I think I've quickly learned that that's not the case. You want to spend a good amount of time speaking to the patient and understanding what the patient's complaining about when they're complaining about it. The simple things we learn early in medical school. So an interesting feature in this patient's history is that she had low intensity exercise intolerance. She had proximal weakness, and this happened later in life. So those are clues here. At least the proximal weakness and that adult onset, you could consider a few things here. You can have a limb girdle muscular dystrophy that shows up late, congenital myopathies, a metabolic myopathy, myotonic dystrophy type 2. They can get proximal weakness. Could be an inflammatory myopathy, which this patient was treated for, and adult SMA, spinal muscular atrophy, right? That's neurogenic. So now that those are our differential pieces, we want to prove it one way or the other. So the EMG showed a myopathic process. We can cross off SMA and type 2 myotonic dystrophy. The biopsy showed significant lipid deposits. So that really narrows it to basically 3 things: primary carnitine deficiency, multiple acyl-CoA dehydrogenase deficiency, and neutral lipid storage disorder. That's it. Those are the 3 things this has to be. Those inflammatory cells, yeah, they're there, but they're not specific. So what labs do we send now? We send carnitine levels. We send a serum acylcarnitine profile, urine organic acids, blood smear. You can look for lipid deposits in white cells. That's for neutral lipid storage disorder. And then a targeted gene test. Right, but if you weren't thinking about this, you're not going to send these labs. So this is a representative biopsy of this patient. It was a different one, but similar presentation. And look at oil red O, right? Those fatty deposits, you don't see those in inflammatory myopathy, so they shouldn't be ignored. You can see that on H&E, and you can also see it on electron microscopy. Those fatty deposits lead you to an answer. And the answer here with her gene testing was suggestive of multiple acyl-CoA dehydrogenase deficiency. It's a mouthful, so you can just call it MAD. And the way I think about inborn errors of metabolism, right? There's several different processes that can be affected in metabolism, but one is with lipids. But generally, when you think about it, right, we have the newborn onset, which is devastating. It progresses quite rapidly, it's multi-system involvement, and patients decline and demise, unfortunately, quite rapidly. Then you have less severe that shows up a bit later in life, childhood, teenage years. And then you have late life, right? Adult onset, where these patients are quite mild, they go misdiagnosed for several years, and eventually you come to an answer. Interestingly, right, B2 or not B2, there isn't a question in this case because B2, you give these patients and 99% respond. It's riboflavin responsive, MAD is the description of it. And so you can see in one case series here that these patients have quite a bit of diagnostic delay, 0 to 29 years. Whoever did the 0 years is quite great. And you give them riboflavin and they start to respond. And that's what happened to this patient. We gave her B2, she started walking again and was back to near normal strength. There was functional overlay, that's for sure. But there was pathology there that needed to be treated. The diagnosis here, those flower cells shouldn't be there, but I do like them. And it relates to electron transport flavoprotein dehydrogenase. Boy, biochem is a bit rough and a mouthful, but if you look at the electron transport chain, ETFDH binds with coenzyme Q10 and works with complex 3 to help eventually produce ATP. You see there's different subtypes of ETF, and a cofactor of them is vitamin B2. So on the bottom right, I put a schematic, and what basically happens is that when these proteins have mutations, they get degraded because their energy is too high. And so when you give a chaperone, whether it's an antagonist or agonist, it helps it fold better and stabilizes it to a lower energy state. So the body likes it, it stays there and is able to do some of its job to help the patient. That's called residual enzyme activity. The diagnosis for this, the late onset form is proximal axial weakness. You see lipids, a lot of them. They can have an axonal neuropathy. The labs are what helped give it away too. The acylcarnitine profile, all the different sizes of fatty acids are elevated. If you zoom out in biochem, when you think of the different processes happening with fatty acid beta oxidation, you reduce the number of carbons recursively. But if your terminal endpoint, right, ETFDH, is what's helping transfer that into ATP, if that's broken, everything else backs up, which is why the short, medium, and long chain acylcarnitines are elevated. Urine organic acids, you can see some differences as well, and you treat with riboflavin, which helps these patients. You can give a few of these other cofactors, but riboflavin is the key that you use. All right, this is another clue to the diagnosis here. And King George supposedly had this diagnosis, but it's not true. But we'll go through it here. And this disease entity is associated with vampires. So this is a 58-year-old woman, and she had proximal weakness and balance changes. So she came to me after she had this abrupt abdominal pain. She had 20 pounds weight loss. She had a cholecystectomy. There's no clear reason, but once you're there, I guess you take it out. She had 1 week post-op, tingling in her hands and toes. She had pain progression up her arms and legs, and she had proximal weakness. She was getting falls and balance issues. Her symptoms plateaued, but the abdominal and nerve pain persisted cyclically. The nerve pain was there relatively constantly. Her CK was normal, her aldolase was very mildly elevated, and then EMG showed a mild sensory neuropathy. A PAN scan, CT chest, abdomen, pelvis, MRI brain, CT spine, all of that was normal. MRI C and T spine were normal. EMG again did not suggest a myopathy and sent off a few other labs here. Her review of systems, she was anxious, she was a bit irritable, no ocular bulbar symptoms, autonomic review of systems was okay, no neuromuscular diseases. She did use alcohol and tobacco, and that somewhat correlated with her symptoms. And those are medications listed there. Her exam, significant for proximal and very mild axial weakness. Her ankle reflex was down. She had a length-dependent neuropathy, small and large fiber, and she couldn't stand up by herself, given the weakness and the neuropathy. Mentioned that the aldolase was mildly elevated. Sjogren's antibody was elevated, but she didn't have any symptomology to suggest Sjogren's. Her LFTs were abnormal, and the rest of her workup there I list for you. was unremarkable. So think about this for a moment and where you would place this patient and what do you think is happening? What are some of the salient features from the history? What are some of the salient features from the exam? And where you would localize this to? So same kind of thing here, right? Where I think about where, excellent. So I see a comment here about abdominal pain. I love it. Right, it's unusual. We, as neurologists, we don't normally think of abdominal pain unless there's autonomic symptoms, perhaps, if there's gastroparesis. But really, that's something that gets brushed aside. But good. I like that you're thinking about that and including that as part of your differential. So there's a myopathy pattern of weakness, but CK is normal. The EMG does not suggest a myopathy. There's a neuropathy, definitely. And if we just kind of go through our different differential diagnoses here, this patient was thought to have, well, is there myositis? Because, well, the aldolase is elevated and she had weakness in that pattern. Well, it's neuropathic pain that she has. She has EMG, there's no myopathy, there's no rashes, so unlikely. Is there a sensory ganglionopathy with some of the severe neuropathy that she had? And it's an important point when there's deafferentation, when there's a ganglionopathy, is sometimes when you've examined these patients, it feels like they have weakness, but it's not true weakness. And what I mean by that, and you can even try this right now, is close your eyes and spread your hands out. Don't hit anybody. And now bring your fingertips together and have them touch. It's a little difficult to do, but you really require your sensory nervous system to tell you where your body is in space. When you take that visual input out, right, that's how we test the Romberg too. When you take that visual system out of it, you really tax your proprioceptive system. So she had some symptoms that may have been suggestive of that. Was the weakness truly there or not? So that's a question. I thought it was there. Great. I see some questions here that are looking for the answer. If anyone has it, just suggest it. But we're all hinting at it with the urine color changes, anemia, abdominal pain. Congenital, was there some kind of congenital syndrome here? Well, it was abrupt onset, doesn't fit. There's no motor neuropathy that fits here. And then early myeloneuropathy, are we seeing some signs that might suggest this again? There's the EMG vibration dissociation and the myopathy pattern of weakness don't fit. I love it. I see porphyria there. And so if we add in the abdominal pain as the metabolic stressor, there's fasting involved here. There's surgery stressor. There's a neuropathy, which sensory and motor findings, and then neuropsychiatric symptoms. Right? She had anxiety, irritability that was seemed to start with all of this. It's easy for us to write off, but it could be a symptom. And those are the three buzzwords to help you get to to porphyria, or AIP. And so tested for that in this patient, and it was positive. Aminoglycovinic acid was elevated, and porphobilinogen in the urine was elevated. You should also test for urine organic acids, as well as heavy metals. So hereditary tyrosinemia type 2 can lead to these false positives. Heavy metals, particularly lead, can lead to these false positives. And the test to do for these patients is ALA, urine ALA. You don't need the 24-hour test. And then PBG, porphobilinogen. When you just send urine porphyrins randomly, like that middle panel there that lists all the different kind of porphyrins that are difficult to pronounce, that's non-specific. So if there's liver disease, if they're on certain medications, I talked about the other diseases, you might see that. But urine aminoglycovinic acid and porphobilinogen are great tests to do to help screen. We know that it can be falsely negative outside of a flare. It typically shows up in women 20 to 40 years of age during the luteal phase of their menstrual cycle. And during that time, they have quite prominent abdominal pain. About 90% or so present with abdominal pain. They are categorized as pain-seeking patients, functional neurologic disorder, and only 50% have the triad of psychiatric symptoms, abdominal pain, and neurologic symptoms. Right, only 50%. So think of abdominal pain as the buzzword to help you get there, and then you have to, reassess the different symptoms to make them fit. I put an MRI picture there. That's what she had. For her, there's a diagnosis. It's often misdiagnosed as a few things. One, they get acute motor neuropathies, typically the arms. more than the legs, but they can get the legs involved and they get proximal weakness. And so there's sometimes a misdiagnosis of Guillain-Barré, the motor variant. Sometimes there's misdiagnosis with multiple sclerosis. They get these non-specific white matter lesions. So that's what her picture looked like. And I think that's related to her porphyria. And then myositis is sometimes misdiagnosed as well. With that, the aldolase can pop up if there's some liver issues. These are called acute hepatic porphyrias. There's also the dermatologic ones as well. But AIP, AHP, AIP is a category within AHP. And then they get proximal weakness. It can be symmetric if it's more fulminant. So again, to think about porphyria in this case, given the different symptoms this patient has, and you all nailed it perfectly there. The King George reference, that is, he was thought to have porphyria, but that's not the case. He was just mad for other reasons. And then we also have the vampire thing there. So the urine color change, the teeth can change colors. That's the different porphyrins and the pigmentation that they give off. The classic story that we talk about, which no one leaves urine sitting out, but if you leave it sitting out with UV exposure, you see that the color can change. And then there was thought that garlic facilitates heme degradation, which is not the case. And so anyways, vampires don't like garlic because it led to porphyria flares. Been proven false. But in any case, when you think of these patients, they're out there and they can be diagnosed if you're thinking about the symptomology. So she doesn't need immunosuppression. And there's various treatments that you can do where you say, don't fast, make sure you're not on medications that can lead to flares, avoid smoking and alcohol. You give them heme and glucose if they're in an acute flare. And then there's siRNA that you can do to knock down mRNA levels of aminoleucovenic acid, which is thought to be the neurotoxic agent for this disease. All right. Well, I talked about all this right now. Let's see if I missed anything. I think that's it. Well, good. I talked about all that stuff. Very good. So myositis mimics. All right. I think the most important lesson that some of the most important lessons that I've learned from Dr. Milligan and my other mentors is know where you're going, right? Know from the history and physical what your differential is, what's your hypothesis, and have an intuition to say, I think this patient lands here. I think this is infectious. I think it's inflammatory. And then know the limitations and benefits of your labs, right? They are your tools. You don't need to let the tools make the clinical decision. So CK, right, where you take caution, it can be elevated in acute denervation. Aldolase can be elevated with liver injury, which is the case for this porphyria patient. EMG gives you a process, not a diagnosis. Inflammatory biopsies can be seen in several different conditions, such as various dystrophies. And the MRI muscle is often read as myositis, but you can see that with different kinds of issues, including denervation changes, metabolic or genetic myopathies. Flares in muscle diseases can happen, or neurology diseases or neuromuscular diseases, if you have metabolic myopathies or junctional disorders like Lambert-Eaton or myasthenia gravis, not just myositis. So to summarize the different cases that we talked about, we had a sarcoid IBM overlap. We had HTLV1 associated with myopathy and myelopathy. We had a riboflavin responsive MAD, multiple acyl-CoA dehydrogenase deficiency, which is a metabolic myopathy. And then we had acute intermittent porphyria. I won't talk about myocyte signaling, but muscle talks to the rest of the body. It's quite fascinating. It's an endocrine organ. That's all I have for you. Please, questions, comments, anything you want to talk about, happy to chat.